Okay, Dr. Muhammad, you can ask your question, please.
Assalamu alaikum.
Wa alaikum assalam.
نورت والله.
حياكم الله. Really nice to see all our friends from different countries, and it's actually really nice gathering. Actually, my question, because I have patient actually who's not responding to anything. I did laser, focal laser. I did all type of anti-VEGF, and I inject him with Ozordex. And the patient is really nice and kind, and he's trusting me too much. And he's not responding. Actually, honest to God. What's left with is either Leuven or surgery, because the edema is really significant edema. Although the vision is 20/60, but OCT findings show really significant edema. So by chance, the patient went to France, and one of the retina specialists was suggesting for him Leuven. Although I'm not convinced that Leuven will help, because as far as I know, that if the patient is not responding to Ozurdex, then he most likely will not respond to Leuven. So my question: do you recommend Leuven for such patient, although the patient is paying from his pocket, and the edema is bilateral?
Okay, so is it both eyes that are resistant even to Ozurdex?
Yes. Actually, similar picture OCT finding, and vision is 20/50, 20/60, and not responding at all to both eyes.
Is there any epiretinal membrane?
Not really, no.
So what I will do is I'll divert, because I've been quite lucky with my patients. So I've never had a patient who's not responded to steroid.
Excuse me, Dr. Fahad, can I interrupt you? I want actually to take an opinion of Dr. Ammar about this one, then I will come back.
This was my suggestion. This was my suggestion.
I'd like to see Dr. Ammar, because this one, there is a surgical, opinion, and at the same time, there is a medical. So let us ask Dr. Ammar, Dr. Abdullah, their opinion, and I will come back to you. Sorry for that.
No problem.
So honestly, in this situation that was described, with the trial of Ozurdex in both eyes with no response whatsoever, I think that Iluvien will be unlikely to work, in my opinion. And sometimes, even if there is no clear epiretinal membrane that's causing a significant contraction of the retina, there might be actually some taut ILM that is causing the edema, especially when you're telling us that the vision is 20/60, 20/50. So hopefully at least the outer retina is not completely damaged. So in this case, I would potentially favor surgery actually with ILM peeling over trying Iluvien, given the fact that the patient has already received steroid injections and did not really fare well with that. So that would be my opinion at this point, with the bias of being a surgeon, obviously.
Thank you, Dr. Muhammad. Both Muhammad, thank you. Muhammad Al-Malki, also thank you for bringing this to the up. I believe, and I agree with you, that there is some minority of our patients is not responding and they still have macular edema. And since you bring it to the surface by saying it's in bilateral, in most of those cases, they have uncontrolled blood pressure, or they have nearly not yet end stage renal failure, in which they have a spike of blood pressure, and those can aggravate the macular edema they have, and no matter what you inject him, he will never be improved unless you control the blood pressure in those cases. Plus, if the patient is not responding to Ozurdex, we cannot blame the Ozurdex itself. We can think of another way, that either the dose of the steroid is not enough for this patient per se, or patient really need more than superimposed injections by anti-VEGF or something else. And I don't mind to inject him if he can pay for it or the assurance can pay for it. But I keep in mind that vitrectomy could be a solution in particularly after inject the patient. I don't do the surgery without injection actually, because you need the macula to be the minimum that you can have as a macular edema, because peeling the eye limb peeling, there is a rule. There is many surgeons believe that vitrectomy in a diabetic patient, it's better to peel the eye limb peeling, which is not totally correct, but sometimes it's maybe wise of thinking in a such way. But peeling the membrane of the eye limb peeling in a macular edema, this may aggravate and may cause adhesives like injury to the tissue. And this is why in those patients, I don't expect a lot of visual acuity improvement in some of them, even if he improved anatomically by the OCT. So I keep in mind vitrectomy is one of the list, but it's not the only things that I'm thinking of.
Can I
from
comment on that or no?
Yeah,
just a follow-up comment. So just to follow Dr. Abdullah's thinking, if we feel like the dose is not enough from Ozurdex, then I think at that point, really, Iluvien is not the choice to go with, because we all know that the dose of Iluvien delivered is lower than Ozurdex. That's number one. Number two, I think the goal here, whether we predict a good visual acuity or not, is to look at the details of the OCT. If we have a normal outer retina in the foveal area, then I think that it will be reasonable to expect some improvement in the vision. If the outer retina is not good and you have damage in the photoreceptor layers, then at that point it will be just an improvement in the edema on the OCT without expecting visual improvement. Those are tough cases, and yes, I agree. We have to always look at the systemic issues to whether the sugar is controlled, the blood pressure is controlled, and all of the other factors. Sometimes also some medications can cause macular edema and need to be removed. So lots of complicated factors that need to be looked at.
So there is a lot of debate here. So let us go to take the answer of Dr.
Can I just
Fahad.
say? Can I just add one thing, Dr. Amri?
Okay, then I will give my comment, please.
So although I support what my two colleagues have said, and I think surgery is probably the best course of action for this particular patient, we still don't have any good clinical trials to support this approach, although I think this is the right way. So in the UK, they are trying to enroll a prospective trial where they're comparing the role of vitrectomy in patients with persistent diabetic macular edema that have not responded to intravitreal therapy, and comparing it with continuing with intravitreal therapy.
So what is
so it's called the video trial. Now they've had difficulty recruiting, and obviously with this COVID crisis, recruitment's going to become even worse. But hopefully in the next couple of years, we're going to have some good prospective data where I think it will be much clearer where these persistent patients that aren't responding to these very good drugs, where surgery is probably the answer for them.
Okay, Dr. Fahad, so if this is the case, what are you going to do? You will prefer to give, you can give here Iluvien, you will give a trial of Iluvien or not? I mean, yes
in
or
this
no?
case, no. I would like Mr. Safar and Dr. Abdullah, I would see if there's any systemic issues, but if I've controlled those, I would refer him to my vitreoretinal colleague to consider for surgery. I would
Actually,
not give Iluvien.
a small comment about this one, actually. I have a case. They are not responding to anti-VEGF, but it's not similar, I mean, to Dr. Muhammad Al-Malki exactly. But I'm not responding to steroid. I try also Ozurdex. Then I give Iluvien in the case, diabetic macular edema, and there was a very good improvement. Actually, it's improved from 0.1 to 0.3, 2 lines improvements, even though I thought it will not be an improvement. I don't have an explanation why it's not responding to that, but I tried this one and it worked. Doesn't mean this is, I mean, it's it can be a rule, but it is this what I have in one case like this one. Actually, we are having a lot of colleagues, they want to talk, but still we are having another 2 speakers. So we will be very fast, and I will not apologize. I will say I will wait after at least Dr. Abdullah. We'll have another couple of questions. then Dr. Ammar, another couple of questions, then we'll have a majority of questions at the end. We will be a little bit fast because, you know, the time also is running. I don't think that's the time it will run like fast like this one. So can we just take, excuse from my dear colleagues, Dr. Nazim, Dr. Ahmed Al-Barqi, Dr. Safwan, Dr. Al-Abri, Khalaf. So just after Dr. Abdullah will take their question. Dr. Abdullah, can you just start your talk or case? Thank you.
Dr. Muhammad and the guys there, thank you very much for this gathering. Since we are socially keeping distance, but virtually we are gathering. And, my talk is going to be about this case. I will be very brief, so we leave some time for the discussion. Do you hear me, Dr. Muhammad?
Yes, Dr. Abdullah, everything is very clear, please. You can go ahead.
So this is a male patient, 40-year male patient who has pseudophakia in the left eye. And actually this pseudophakia in the left eye is because of he was having a retinal detachment, operated, having vitrectomy. So at this age, he developed that cataract in which he get operated. Patient is a known case of glaucoma, also on Lumigan. So he's diabetic since 11 years. This diabetic macular edema since 2 years. Patient has been given 8 anti-VEGF and 2 Ozurdex before he came to us, and we decide to give him the Illumi. After revising his chart that he bring it all with, you can see the change. He was giving 2 times of Ozurdex actually, and this will bring us to the talk that was given by Dr. Fahad, that sometimes you need to give anti-VEGF injection even during the early phase of the dexamethasone or the steroid injection. So he has injection, improvement in the thickness, then he needs another injection, then improvement in the thickness, and this is the normal chronic timeline with our patient. If you see at the beginning with this macular thickness, this is exactly the same. I just want to bring to attention in this case that visual acuity is the same, even though the macular edema a little bit improved. And even though after a big improvement, it's not really correlated with the macular edema. And after sometimes, even the visual acuity become a little bit improved, but he came back with more macular edema, to bring to attention that sometimes visual acuity is not every time correlated with the macular thickness. Sometimes you may have a visual acuity who improved lately. Sometimes you may have a bias in measuring the visual acuity depending on the patient cooperation in getting the response when you take the visual acuity. As you know, visual acuity is subjective and the OCT is objective, and maybe this is why we have this difference. After 1 month of 11 injection, and this has been a few years back actually, patient still has an macular edema, and this is why I ask you, Dr. Fahad, do you have a fast response? Actually, in most of my case that I give the Leuven, they don't improve in the first month. And this is why I keep in my mind that I am going to give them anti-VEGF at least once or 2 till what I call it myself a loading dose, because I need to give the time for the drug to be dissolved in the vitreous and to be disseminated and arrive to the retina. And this is, in my opinion, take time. So what I'm trying to bring to attention that in some elements in that patient has a glaucoma and he's treated by prostaglandin. And every time at the night when he put the prostaglandin, early morning, he developed a red eye. So behind me, without telling me, he take a 1 drop of Bradford just to go to the work nicely without bothering of the irritation. And he continue that all the time till he declared it to me. So I was thinking, is this red eye or mild uveitis, which is +1, that we get rid of by 1 drop of Bradford, is really related to the prostaglandin, and does we really need to take care of it or stop it, change it? So I proposed to him to change it to another medications. He tried, but then he said, well, I'd like to have a red eye plus 1 times per day rather than taking 3 drugs or 3 times per day, since I am flight normally. He work in agency of a flight organization, so he flight a lot, and his assurance get covered by in Saudi Arabia, not any other place. So at that time, there was now really correlation clear between prostaglandin and the macular edema or the red eye, because after my digging behind it, I found this study which showed that there is a relation between prostaglandin and macular edema in some experiment on rats who has diabetic induced for study. Then after a while, which is proven, the Northen become approved for treatment of some uveitis cases. So what is the case element in this guy is he has a diabetic macular edema which is resistant. He is on glaucoma and controlled by prostaglandin, which cause red eye plus, in my belief, some chronic mild macular edema. The patient already vitrectomized, so the dose that we can expect from the pharmacodynamic and pharmacokinetics regarding these medications is going to be changing because the material that we put the medication in is already changed. Red eye and uveitis disappear totally after giving the patient an Ozurdex or after giving the patient a Northen. So this is why I put in my mind that, listen, Ozurdex injection or intravitreal injection by cortisone or steroid, whether Ozurdex or fluocinolone or a Northen, is equal to my opinion to 1 or 2 drops per day only of Predfort. And this could be the maintenance dose of controlling those uveitis for the guys who treat uveitis. So this is the implant, in which is very thin, easy, sharp to be inserted, and it's steroid. I believe steroid is there to stay because of the interleukin 8 or 11 or 6 that has been mentioned by Dr. Fahad is treated properly by the steroid. It blocks many mechanisms that control to treat the macular edema. Does it has the effect fast? No, it needs time to work because steroid is controlling the element that cause macular edema indirectly, and not like anti-VEGF that work immediately, which is controlling the VEGF that cause macular edema immediately also. This is the case after 6 months, in which the patient improve, still some cystic changes in the macula, but generally the eye become better. I'm not gonna dig behind those studies, has been mentioned by Dr. Fahad. This is also the famous study which showed the improvement within 24 and 36 years. And when you talk about Northen, you talk about cost preservation, and you talk about a long run management for our patient that we expect they will take a longer time to be treated. I see one of the questions someone asked, can I give more than 1 Northen? Definitely you can give more than 1 Northen, but after you spend 3 years for the first Northen, you can start the second Northen, as some cases take 5 years to get treated in those cases. And even some very rare cases, you may take many years just to treat those macular edema and to suppress this chronic inflammation. This is also a study has been mentioned before. So it's an indication for diabetic macular edema and uveitis. And I'd like to give you this 2-minute video in which a VIB patient who already having a heart problem. So we decide to treat him with Northen out of label, as at that time it's not yet approved by the Saudi FDA. And as you see, the patient is not really cooperative. He looked right and left many times. Patient is on aspirin, and I don't stop aspirin at all in any surgery that I'm doing, neither cataract, neither intravitreal, neither retina surgery. I'm thinking twice of Plavix or low molecular weight heparin. I definitely will refer the patient for hematology to stop it. but I'm not going to stop aspirin for those surgery. As you see, there is a oozing of the conjunctiva, and this is, if you are lucky, it's not going to cause subconjunctival hemorrhage. But I use not to give, not to stop any aspirin during those medication. I give subconjunctival local anesthesia in this case, while in the majority of my case, I rarely use a subconjunctival, except for those patients who is really very sensitive, and if they move, they may bother you. So I used also to wash 2 times with betadine, 1 by the nurse, 1 by me, unless the nurse didn't do it, so I do it myself. And I think this is very helpful in giving a good sterilization. Those who have, of our colleague who have tried the Ozurdex and the Iluvin, they realize how much soft to inject the Iluvin, as it is, there is no click actually to insert it inside the eye. After you remove it, you just take it out and try to slip the conjunctiva over the hole that you create, so to avoid any, to seal that hole and to cause less infection. Washing is very important to make patient avoiding the post sterilization irritation by betadine, and it's 5%, of course, as all of us know. And patching the patient, I see them most of the time after 3 or 4 days, just to make sure that the patient doesn't have any endophthalmitis, as this is the time you can get an endophthalmitis. Endophthalmitis, you cannot diagnose it first day or second day or third day. So I ask the patient not to touch his eye, to keep the eye patch for 1 day, and not to wash the eye for 2 days or 3 days. And I see him on the 3rd day or 4th day. So this is the last. Can the Iluvin be displaced to the anterior chamber? Actually, yes. And the difference between the displacement of the Iluvin and the Ozurdex is the Ozurdex is biodegradable. So whenever you hold it, if it came to the anterior chamber after a few times, it will become very fragile to hold it with the forceps. And unfortunately, I didn't bring the video that whenever you try to grasp the Ozurdex in the anterior chamber with the Retina forceps, it's get divided to many pieces, and it make removal is a very difficult. While in the Iluvin, it's easy to grasp it with the forceps and to remove it out. Even though corneal decompensation or endothelial decompensation is very fast whenever you have those cases. I think this is my part. Before I'm closing, I was thinking as an advice for the manufacturing, if they can divide their instrument to 2 parts. Part in which the dissolving is very fast, and we can call it a loading dose part. Then the other part, we can call it a maintenance dose part. And I think if they succeed to do that, maybe we will not need to inject an anti-VEGF on the premier phase or early in those cases. Thank you, and again for the invitation, Dr. Mohammed.
Thank you very much, Dr. Abdullah. It's a good case presentation. Are you hearing me? Okay, it's okay. The voice is clear for everyone.
Yeah.
Okay, I think the case is very interesting, Abdullah. For questions, we are having a question. If there is any comment from Dr. Ammar before we go, then Dr. Fahad, then we'll have a few questions from dear colleagues out. Yes, Dr.
I have a quick comment, just with the, with the injection of the Iluvien. It's a little bit different than Ozurdex in the sense that it's advised not to tunnel. With the Ozurdex, you kind of like go in an angle and tunnel it, and then you go perpendicular. In this case, it's a little different, where you need to just go perpendicular, because you could actually run the risk of bending the needle if you're doing that. So we just need to go perpendicular, which exactly like what Dr. Abdullah showed on his video. The other comment I just had, which is the issue that I think Fahad alluded to in his presentation, is loading, like when we give the injection and we don't see a response in the first month or 2, we get anxious, we start covering with and adding. And I think the more experienced we become in doing these injections, the more relaxed we become in potentially tolerating some edema the first month or two until and I don't claim to be experienced in this because I'm new to Iluvien, but I think this is something that we need to kind of like look at and maybe avoid additional injections in the first couple of months after the injection, after the Iluvien.
No, just to,
Okay. Thank you, Dr. Ammar. Yes, Dr. Fahad.
no, just to add a comment. I think prior to Protocol V, I don't think although anecdotally, you know the eye tolerates a bit of edema, particularly in diabetic macular edema, I was quite anxious about watching edema, and I would always want to get as dry a macula as possible. Now I think it's about looking at the patient and the function for that patient. So if you've given them an intervention, it stabilizes things, they're subjectively improved, then like Dr. Abdullah and Dr. Ammar has said, it could be that you could hold fire. You don't have to necessarily give an additional treatment. But like I would just caution you that I would watch those patients carefully, because if their vision does decline, you can then intervene.
Okay. Thank you, Dr. Abdullah. Now we'll have a few questions. We'll start by Dr. Safwan Al-Bayati. Yes, Mr. John, can you just open the mic for Dr. Safwan? Let him give his question, please. Yes, Dr. Safwan, please. Can you just, Dr. Safwan, open the mic, please? Open the mic, Dr. Safwan. Okay.
It's clear?
Yes, now we can hear you, please. Yeah, all the time.
Okay.
Open the mic,
So,
please.
Assalamu alaikum, everyone.
Well,
It was a very nice discussion, and I'd like to thank Dr. Muhammad definitely for this organized meeting, and Dr. Fahad for a nice presentation, and Dr. Abdullah Al-Qahtani. And I'd like to comment a few things related to what Dr. Abdullah Al-Qahtani mentioned first about the prostaglandin analog, and that's very important because we are facing a lot of patients coming with persistent macular edema, and they took a lot of treatment apart from anti-VEGF and steroid, but still the persistent macular edema there, and because and they are taking anti-glaucoma drops as an prostaglandin analog. And there is a lot of study. It's not only on animals like what's present. No, there's a lot of studies shows clearly that the role of prostaglandin in macular edema, especially for those that they are reliable to have a macular edema like diabetic and other causes of macular edema. Staying in diabetic, I've got a lot of patients, at least the 3 or 4 that I remember, they had at least 22 to 25 injection anti-VEGF with a prostaglandin. So once I stopped the prostaglandin, shifting it to another anti-glaucoma, and I start with a few steroids injection, then all their condition is subside. So we need to be careful when we are prescribing or dealing with patients that they have a persistent, they considered that they have a persistent macular edema, but the issues is related to the prostaglandin analog medications. The second issues that I need to just to comment, I do agree fully with the Dr. Ammar for the condition of persistent macular edema. First of all, we need to define what's the persistent macular edema when we are starting. So those patients that they've been treated with the anti-VEGF, and then we found that they are not responding, and then fluorescein done to see if there is any local focal macular leak or paramacular capillary free zone area or in the periphery, and they've been treated. So those patients that they've been treated well with the laser for the periphery, for any capillary free zone area and the central, and then still we have a persistent, then we start Azordex and still we have a persistent. And then after all, for me, 7 injections and up to 10. So in these cases, if the Ozurdex used after all these series of the anti-VEGF, and then there's no response, I do agree fully with Dr. Ammar that I have few cases, 3 or 4 cases, that I went to the ILM peeling, and there's a study, definitely a series of studies coming from 2003 up to now, and it's done, by the way, it's an accident study done by one of the pioneer in vitreoretinal. He's a French, I'm not remembering his name. Now here, accidentally, they did the ILM peeling for a reason of vitreous hemorrhage done, and then they found that the macula is subsided. And we all know the story behind. So that's right, as Abdullah said, the risk of creating a macular hole is still there, but those that they have this persistent and the anatomically resolved, I think that our aim in that persistent macular edema is to maintain the vision, not to improve it. In spite of that, my patients, however, those 3, they gain at least 2 lines. So as Fahad also said, when we don't have any hop, especially when Ozurdex is not work, then we need to go through, not to wait for Leuven to work 3 years and then we will go to surgery. That I'm not with. Great, thanks for everyone, and good luck for everyone.
Thank you, Dr. Safwan. We can have now Dr. Muhammad Al-Abri, please. Dr. Muhammad from Oman, a vitreoretinal surgeon, dear friends. Can you open the mic for Dr. Muhammad Al-Abri, please, to give? And I would like to ask my dear colleagues to be very fast in their comment and questions, because we are running on the time. Dr. Muhammad. Okay, Dr. Muhammad Al-Abri. After Dr. Muhammad Al-Abri, we will have Dr. Nadim Al-Hussein. So Dr. Nadim, prepare yourself after Dr. Muhammad Al-Abri. تفضل دكتور محمد، تفضل.
السلام عليكم دكتور محمد، تسمعني؟
وعليكم السلام، نسمعك دكتور محمد بكل وضوح، تفضل.
جزاكم الله خير، شكرا على السيشن. سؤالي ببساطة للدكتور فهد بالنسبة ل challenging cases of that you consider steroid. Do you understand you challenge them with Ozurdex, or you challenge them with off-label triamcinolone like Canolog or others?
Very good question. So in the UK, we're regulated by the General Medical Council, and they are very clear that you should only offer patients licensed medications. So in the UK, I can use Ozurdex for the treatment of diabetic macular edema. And so when I challenge a patient where I think steroid will make a difference, I will give a steroid Ozurdex injection. And then if there's a good response, I will then switch 2 months later to give them Iluvien to maintain that benefit. I am rarely using Canolog, and I'm only ever using it in the odd circumstance where there is no licensed alternative. So it's in conditions where we have no medications. For diabetic macular edema, I'm using Ozurdex as my challenge, but then I'm switching to Iluvien. I'm not giving 2 or 3 Ozurdexes.
Okay, Dr. Fahad, thank you. Dr. Nadim, Dr. Muhammad, you have any other questions?
Lately, we used to use Triasins from Alcon, which is approved for injecting the eye, and preservative-free is doing very well actually, but lately it's out of stock from the region. So that's why I'm asking. It's we do have challenging patients they need Ozurdex and Iluvien, but unfortunately Triasins are not in the market anymore.
Thank you.
Thank you.
Thank you, Dr. Muhammad. Okay, we can have now Dr. Nadim. Till Dr. Nadim open, I have a question for you, for Dr. Ammar, Dr. Fahad, or Dr. Abdullah. Anyone can give his comment.
Okay, can you hear
me? Yes, Dr. Nadim. Please.
So, just to reiterate that I was a principal investigating study. Both was central headquarters. Hear me?
Feedback. There's feedback.
There is a lot of feedback. Can you please make our voice very less? Then ask the question. Then you can raise the volume, please. Yes. Now we can ask.
I just want to say that I was involved in the film study. Okay, so I was involved in the central retinal vein obtaining study of film study as well as the diabetic study for making it was meeting before.
Dr. Nadeem, I think there is a lot of sounds behind you, so we cannot hear you well. Can you just please be in a place there is no echo for that place? Because or we are not hearing anything from you.
Okay, let me try.
Okay, we can take another question from another colleague till you prepare yourself. We can take Dr. Ahmed Al-Barqi. Dr. Ahmed Al-Barqi, please, if he is a questions. John, please open for Dr. Ahmed Al-Barqi. I was asking if there is a possibility, or is it good, I mean, or it's okay to use only drops, for example, prednisolone 1%. Is it okay to use it and as a testing for the patient for increased intraocular pressure? I mean, for 1 week, every 1 hour.
Hello?
Yes, Dr. Ahmed, we can hear you. Please let us take Ahmed Al-Barqi.
Assalamu alaikum جميعا. Thank you, Dr. Muhammad. I want to also thank Dr. Fahd Al-Kahil, and I wish all the best and in the current situation in UK to be under control, inshallah. So, Dr. Abdullah Qahtani, missing you so much, my dear friend.
You too, brother.
Just to be short, as Dr. Muhammad wanted, I just want to share my experience because there was a nice case about a non-responder for the one of the attendees, I think Dr. Muhammad Al-Abri, I believe. He asked about he showed one case that bilateral edema and is not responding, and
Muhammad Al-Maliki from Saudi.
Sorry, Muhammad Al-Maliki. Yeah, his nice case. And he gave, I think, focal laser, anti-VEGF, Ozurdex, and does not respond. One of my cases, and it has I have the almost same patient, does not respond to anything. As I think all of you demonstrate that macular edema, sometimes we facing a problem that does not respond because many other reasons like hypertension, hyperlipidemia, and also still there is some factors behind the DME away from the inflammation and the anti-VEGF. And as you know, the new drugs coming in the pipelines, they are working differently with very remote mode of action. I don't want to go through that, but at the end of the day, we have some resistant cases. So in this case, I discussed with the patient because personally, I am against vitrectomy in DME if there is no any sign of traction, either tangential or longitudinal, because the study available, it's not randomized controlled trial. It's just a few cases, like 20 cases, 12 cases like that. And there is no randomized controlled trial because we should think about the risk benefit of the vitrectomy in diabetic patient. We know the complication of that. So for me, I don't believe in vitrectomy in resistant cases of DME without any sign of traction. So in this patient, just to make it short, I discuss with the patient and I try with him Northen. And surprisingly, I was surprised that it worked, and the edema, it does not go away for sure, but it improved by like 40% improvement. And it came to my mind that, yeah, we use word steroids, but not all the steroids are the same. And they give you another example that might prove my theory, because real life. I have a patient also that he has 3 times got Ozurdex, and he never developed any IOP rise. And when I switch him to Elovin, he developed IOP high. And I think this patient, we have done Ahmed Val for him. And but he's now pressure is controlled and macula is dry. But I think so. The idea of corticosteroid is not all the same. It's different. Flunarizolone from Ozurdex or triamcinolone or prednisolone. Every corticosteroid is a big family, but every member of this family act differently, and also the side effect could be differently. So that's my only comment about this case. Just to share my experience with you.
Thank you, Ahmed.
Thank you, Dr. Ahmed, for your comment. I think if you'll go to direct our now discussion to do vitrectomy or to give injection, it will take a long time.
Yeah, it's debatable. Yeah, debatable issue.
Yeah, debatable. So we will give the comment after we take Dr. Nadim Al-Hussein questions, because Dr. Ahmed he shared his, comment and feedback about the case. So Dr. Nadim, if you can hear us now, can you please start?
Yeah, I can hear you. Can you hear me?
Yeah, it is better than before, yes.
Yeah, so I was involved in the FAME study. So what I understood is that if what I feel is that if the edema is not decreasing even after Iluvien injection, I may consider giving an anti-VEGF injection as a top-up after observation for 3 months. And if that doesn't resolve, then as I would accept to understand what Amar has said, understanding that if there is any thickening in the posterior hyaloid phase, I might go ahead and do a surgery. So that's what I want to tell. But most of the time, if it was responding to steroid like Ozurdex, then it should respond to Iluvien. And often it may happen that after, it may take 2-3 months to respond. And if it does not, if anti-VEGF top up may help it to respond. That is my comment.
Thank you, Dr. Nadim. I think we are going to discuss these points at the end, but still we are having, I will get only one, and the last one for the from our attendees, Dr. Khalifa. Yes, please, can you open the mic for Dr. Khalifa to give his comment? Then we will have Dr. Ammar presentation. Dr. Ammar and me, we are start sleeping, so we need
it's still 7 o'clock, 7:30 in the UK. I'm wide awake.
Okay, but Abdullah already is done. He can go sleep easily. But Dr. Ammar, we are still. Yes, Dr. Khalifa, you can hear. You can please start.
Can you hear me?
Yeah, we are hearing you very well, please.
Hope everybody stays safe. My question is that in these cases that you intend to give an anti-VEGF over Iluvien, would you go to the same anti-VEGF that you was injected in the first time, or will you switch when giving the adjuvant anti-VEGF with the Iluvien? For example, if we started with the Lucentis and we failed to have what we want to have, and we switched to Iluvien, when we are following up and we don't have that response that we need, do you inject the same Lucentis injection, or you go for Eylea, for example, or whatever it is?
Okay, it's very clear question. Just to know, Dr. Muhammad, you are talking from us from where?
From Lebanon.
Dr. Muhammad Khalifa, a vitreoretinal surgeon. Yes, welcome, Dr. Muhammad.
Thank you.
So any comment from anyone of their colleagues, Fahad, Ammar, or Abdullah, about the question of Dr. Muhammad?
So for me, yeah, I would, it depends where the edema is. So if there's a recurrence outside the central 1 millimeter, so outside the FAS, then I consider macular laser. But if there's a central edema at the fovea, I would treat them with the same anti-VEGF injection, anti-VEGF agent that they failed previously.
So he was asking about if we are going to use another anti-VEGF. That
no, I don't switch. I just use.
Don't switch.
If on Lucentis, I give them Lucentis again.
Dr. Ammar, what do you think?
For me, well, the question that Hamad is posing is yes, I would probably go back to the same one. But I typically, what I would do is, if I've reached a point where I'm using steroid, if I started with the Lucentis and I don't get the response, then I first go to Eylea. And then if I don't get response from Eylea, then I will go to a steroid. So let's say that was the question. So let's say I gave the steroid and I need to top up now, then I'll go to Eylea again.
Okay, so you will shift, for example, but because you are still shifting from one anti-VEGF to another one. This is another debate we will go through. Dr. Abdullah?
Actually, I don't shift between anti-VEGF since I start with Eylea at the beginning. I wait 3 to 6 injections before, and whenever I have less than 20%, which is the definition of less efficacy by the guideline of the Retina, I start corticosteroid.
No, but if suppose that after you give, for example, a steroid, whatever it is, Ozurdex or Illuvian, and you want to top up with, or you want to also, you will still continue with the same you start with, or you shift?
I continue with the same.
The same. If you start with Eylea, you will continue with Eylea. If you start with the Lucentis, you will continue with the Lucentis. Okay. So I think Dr. Muhammad, you maybe get the answer. So now we can go. Thank you, Dr. Muhammad, for calling us from Lebanon. And now we'll go to Dr. Ammar, dear brother, Dr. Ammar, my big boss, Dr. Ammar, and he is the one of the representative of our committee, or let us group.
Okay, so thank you so much, Dr. Muhammad. I'm very happy to be with this very nice group. I know it's late for a lot of us, so I'm not going to be long.
You are still in the home, no problem. You can go ahead. Yeah. Everybody is sitting in bed.
So as I mentioned earlier, I am not very, I'm not very experienced with, I'm new to Illuvian, and it just recently got approved by the insurance companies here. So we started using it just recently. So I'm going to show you a few cases, couple of cases actually, very quick ones, to illustrate a couple of points that I started learning from them. And then I'm going to show you a case which is really an unknown or a mystery case, which I will appreciate your participation with, and hopefully this will keep everybody awake. So let's go ahead and start with the first case. This is a 62-year-old female. She is type 2 diabetic, pseudophakic, and she has the history of using Ozurdex in the past, responds well to it, but well only for 3 months, unfortunately, never really gets any better. So this is a picture of her right eye, and after Ozurdex, she gets like this. Then a few months later, she gets another edema and gets another Ozurdex, she improves. So the typical story, and by the way, she has the same exact thing happening in both eyes, but I'm just sparing you the agony of seeing the other eye. I'm just showing you this here. So this is her pictures, like I said. This is the beginning of this year, where at that point, I discussed with her, because now it became available and her insurance covers it, like, how about we actually shift to the to Illuvian? And she accepted that, and luckily we performed the injection, and she actually improved. It took about exactly what Abdullah was saying. It took about 6 weeks to see this kind of OCT, and I think this is probably the typical patients that you can easily start shifting into Illuvian, because they demonstrate a very good response to steroids. And unfortunately, Ozurdex, we know in real life, doesn't really last more than 3 months, maximum 4. So it is actually a very good candidate to switch to Illuvian. The second point I want to make in this case, which is case 2, 72-year-old gentleman, pretty much the same idea. He gets a lot of injections and every 3 months and gets excellent response. But I want to show you his pre-Illuvian injection, and then this is about 8 weeks later. He still has edema, and you know, at this point, I've decided actually to just observe him, because he reported a significant improvement in his vision. And also, I've had the fortune around putting this injection in. I had the fortune of discussing Illuvian with a lot of friends that have experience in this, and they told me just you know, wait a little bit, give it some time. And sure enough, actually, he is improving visually. Now, unfortunately, he called me yesterday. He doesn't want to come to get his eyes checked because of the COVID-19 issue. But I think the point I want to make with this presentation, with this particular case, is that I think it's a totally different response to expect than what we're used to from Ozurdex. Again, because of the difference in the dose. So don't expect them to get better. I think the case that Fahad presented is probably unusual in the sense that it improves dramatically, becomes totally back to normal within 1 month, which is amazing for this lady. So this is basically what I want to talk about as far as Illuvian is concerned. This case here now, I want your input on and participation too, if you don't mind. You can participate by sending your comments or by speaking, depending what Dr. Muhammad Al-Amli wants us to do. So this gentleman, 44-year-old, was referred to me for a vision loss in his right eye. He was recently, the only thing significant in his history, that he was recently admitted to the hospital for acute hypertension, which was put under control. And then during his hospital stay, he mentioned to his doctor that his vision in the right eye was changed. So they referred him for evaluation. Actually, they sent him to an ophthalmologist who referred him to me. No diabetes, no history other than hypertension. So I'm going to show you now his fundus photo, a series of the photos. So this is his right eye, obviously. This is the infrared picture of the same thing. This is the red free. And this is his like sort of an overview of what you would see kind of like in a wide field photography. So I think this picture here, the previous one is really very interesting. Although, hold on for a second, this one here also is quite interesting and helpful, I think. So let's start, I guess, with our friends in the panel here. Any thoughts, any ideas, any questions you want to ask? It's muted.
Fahad from the UK. What's his full blood count?
His, sorry, what?
His full blood count.
Full blood count. Normal. I mean, his CBC is pretty much normal.
So no platelet issue, no pancytopenia.
No. Good question.
What's his racial background?
Filipino.
Could this be polypoidal?
Excellent. Could be. I don't know. Does anyone want more investigation?
ICG?
Okay. It's your lucky day, Dr. Fahad. So first of all, let's go with the OCT first. So this is the OCT showing the section in the center. This is another section up here. So can I just describe this, if you don't mind? I think what we're looking at is multiple layers of hemorrhage, right? So we have pre-retinal, intraretinal, subretinal, sub-RPE even hemorrhage all at the same time. So I think this is a nice clue. Okay, so this is the left eye. I thought somebody might ask, can I see his left eye? This is his left eye. Okay.
Okay.
And
if you have done any CT scan for this patient, Dr. Ammar, CT scan or
of what? Of the head? No, I have not.
Orbit.
Yeah. No, I have not. I have not. Okay, so we booked him for a, like I said, this is his picture here when I saw him, and we said, okay, you need the fluorescein angiogram and ICG. Let's get the approval. We got the approval within literally 24 hours. He's an Emirates employee, and he came back after for the FA, and basically now he has hemorrhage everywhere. There's barely any ability to do anything. Despite that, I said, let's just go ahead and see if anything lights up. So this is his early. On your left is his fluorescein, on your right is his ICG, and you can see that this is his early and this is his late. So now what? So I'm going to give you some treatment options. Inject anti-VEGF, inject Ozurdex, inject Illuvian, or do something else.
I would inject anti-VEGF.
Something else.
I would inject anti-VEGF.
So Abdullah and Fahad will inject anti-VEGF, okay? And Dr. Muhammad is...
No, we don't know what is going on for what I will inject anti-VEGF. This is my opinion, I mean.
Okay. All right, shall we keep going, or shall we look at the question and answers here? Is there any suggestion from anybody?
So can I just ask a question, Dr. Safar? So,
yes, sir.
So there was nothing lighting up on the ICG or the fluorescein to give you even a clue.
Well, I think there was some hotspot, isn't it, Dr. Ammar?
Okay, let me just go back for you. There was actually a something lighting up, yes, but let me see, how can I do this here? There. So you can see something lighting up.
Exactly.
But I couldn't tell exactly where is that really because of the blood. I couldn't see anything. Now, I peeked into the questions here. I mean, the question and answer. I just peeked into it right now, and I think a lot of our audience here kind of like alluded to a diagnosis, which I think is correct. This is a bleeding macroaneurysm. So basically, yeah, and the clue here is the bleeding in multiple layers. When you have pre-retinal, intraretinal, subretinal, all at the same time, is usually the clue that this is a macroaneurysm, especially with the history of recent hypertension. So I wouldn't inject any of these. I actually, especially with his vitreous hemorrhage now in hand motion vision, I took him to surgery. So when I went in, I cleaned up the vitreous, of course. It was really dense at that point. His vitreous was very hard to, clean up, and he's young, relatively young. And then you could see actually that there was a macroaneurysm. This is his post-operative. You can see this area to the temporal part. It's sub-RPE blood, which I, of course, elected not to touch. But there is here, you can see the macroaneurysm. This is artifact. There's nothing here. But there is a macroaneurysm here that kind of bled all over and resulted in this picture. So that's basically a bleeding macroaneurysm that can again, the clue here is bleeding in all layers. I wouldn't recommend draining this part here because you're really going puncturing the RPE, which you will get into so much pathology and so much morbidity if you do that. One other thing that I've seen a lot of macroaneurysms in my career for some reason. I don't know why, but one thing I would also caution you with bleeding macroaneurysms when bleeding happens like this is you could potentially develop a macular hole because of the sudden accumulation of blood underneath the ILM. You actually can create a macular. I've seen 4 cases in my career of macular hole, but just from bleeding macroaneurysms. And this is the picture here. And thank you so much for your attention, and stay safe.
Thank you very much, Dr. Ammar. Especially the last case, it was very, very interesting.
That's a brilliant case, case.
I have one question, Dr. Ammar. For the last, whenever you decide to go, you are having in your mind already that there is a micro aneurysm, or you are still, because we didn't see any real clue except only from the picture, you thought maybe a multiple, but it could be another thing, right?
Okay, so if you remember the picture of the very first, when I saw him with multiple layers, but the vitreous was still clear, I kind of thought that I knew that this is where it's coming from because there was this clot coming out of the superior arcade. But I wanted the angiogram to be done. Unfortunately, the vitreous became very hazy before we could actually do the angiogram. But yes, I was going in 99% sure that this is what it is. But of course, at the same time, having to be careful that it could be something else. So I was ready to kind of like vitrectomize him and inject him if I find that there is no macroaneurysm. And this could be just a breakthrough vitreous hemorrhage from a polyp, for example.
Actually, it was a very great meeting, and we are having a very, very interesting cases and presentation from well-known figures in vitreoretinal, from Dr. Ammar to Dr. Abdullah and Dr. Fahad. We are having a lot of questions. I don't know what can I ask, but I do prefer to have those friends, they want to talk. And I will start by Dr. Ahmed Al-Khashab. Please, dear friend, Dr. Ahmed Al-Khashab, one of the, founders also of North Emirates Dubai Retina Group, and well-known also vitreoretinal surgeon here, like Dr. Ammar. Can we also open for Dr. Ahmed? Please, Dr. Ahmed, you are on live.
Assalamu alaikum, Dr. Muhammad. Dr. Fahd, excellent presentation. Dr. Abdullah, Ammar, as usual. I had actually multiple comments on all the presentations, but I would rather be quick. The last presentation by Dr. Ammar, the one with macroaneurysm, had actually a couple of cases like this one. And yeah, there was the clue with this clot coming out and the hypertension, malignant hypertension, or sudden rise of the blood pressure. And yes, I agree that we should not be injecting without having a clue whether what we are doing, whether the injection would be beneficial or not. One more comment about the Iluven. I think it is a great drug. I had an experience with just a few cases, maybe 5 or 6 cases up to date. But all of them, they are responding very well. One more comment is, as Ammar mentioned, I didn't see the sudden effect of the Iluven within 1 month. I think we should give it time, at least 2 to 3 months to start having the effect. And we should tell our patients from the start that we would not be expecting a great and sudden improvement in visual acuity and central retinal thickness, because this is a long-term treatment. And it is very effective in chronic DME, as Ahmed Al-Barqi just mentioned in his comment about Dr. Mohammed Al-Malki from Saudi Arabia, that yes, even if the Ozurdex is not working, sometimes Iluven would work. But after thorough examination of the OCT and making sure that there is no element of traction or taut post highlight. So we can give a chance for the Iluven. And if it still persists in such case, I would consider still keeping the Iluven inside and go ahead and do vitrectomy like Ammar mentioned. And I would like to thank you all for such a great meeting. And we are lucky actually to have this interaction from all over the region, from Saudi Arabia, from Lebanon, and definitely from here and from Oman with Dr. Mohammed Al-Abri. I don't see all the names, but we are fortunate to have all of you with us tonight.
Thank you, Dr. Ahmed, for your comments. Also, we are having Dr. Hassan Bahrani from Arbil, Al-Iraq. So now we'll have Dr. Saad Wahib from Saudi Arabia. He will have questions. I want just please, if you don't mind, dear colleagues, just we want to be very fast because we don't have a lot of time. We are having only 12 minutes and we didn't cover all the questions. We are having 34 questions still there. So I will ask, yes, Dr. Saad.
Assalamu alaikum.
Can
you hear me?
Yes, we can hear you very well. Yes.
Great. I just want to say hi to everybody. Stay safe. All our friends, Abdullah, even we're in the same city. We still don't see each other. I hope you all stay safe. I have a comment. I totally agree. If you look at the first picture of the last case of Dr. Ammar, you can see supratenally the 3-layer hemorrhage, which I think indicates clearly that this is of macroaneurysm. We do see some cases here, and interestingly, I think it's a bit more common in the Filipino race. I'm not sure why, but I've seen at least 3 cases like this, and depending on the degree of hemorrhage, you would probably decide to intervene. My question to Dr. Ammar, did you have to use any intraocular tamponade? And if you did, what was it?
No, I did not. I'm sorry.
Oh, you did not?
I'm sorry.
Okay, that's great. That's great. I totally agree with the fact that Iluven will take some time. We have some limited experience, but I think this is where combination therapy will be very useful. Thank you again for.
Thank you, Dr. Saad. Thanks you. We are happy that we are having a lot of questions. So we can get. Okay, we can have now Dr. Kavita. Dr. Kavita, please. Fast question, please. It's a long, I know everyone is looking to his watch, especially Dr. Ammar. I can see him, he's going to sleep while he's...
Dr. Amri, actually my question, I'm so sorry.
Yes, Dr. Kavita, please.
Yeah, sorry. Actually, the question was before when he was presenting. Actually, I was wanting to ask, since it is a multi-layered hemorrhage, which is kind of pathognomic for retinal artery macroaneurysm. I just wanted to ask about that and also any systemic associations with it. So it was an earlier question. I'm so sorry.
Okay, thank you, Dr. Kavita. Now we'll have Dr. Prasan Rao. Yeah, please fast if you can. Then prepare, please, Dr.
Can you hear me?
Yeah, we can hear Dr. Prasan. Yeah, go ahead, please.
So I had a question to Dr. Fahad. I think he's already answered it. I'd asked how many patients required anti-VEGF treatment when they were on Illuvium. I think he's already answered. He said 30% of the patients.
Yeah, 30% of my patients. Yeah.
Thank you.
Thank you.
My pleasure.
Thank you, Dr. Prasan. Also, Dr. Prasan, a well-known also veterinary surgeon in Dubai. Dr. Kavita, also veterinary surgeon in the Ministry of Health. We are having still, I think, many questions, but I have, I don't know. I will give very fast for Dr. Hassan Bahrani if he's having a questions very fast. Hassan?
Yes, actually, there was no question. Thank you very much, everybody, for this wonderful conference. Appreciate it.
Thank you, Dr. Hassan. Dr. Khalifa, if we have Dr. Khalifa, please. Also, again, I think he's having a comment. Is there a question?
I have a question on the last minute. What are you doing, guys, nowadays? Are you doing these injections and this COVID-19 crisis, or you still postpone the patients, or what are you doing in the real world now?
Okay, let us have a quick answer from each of, because we are in different area. Dr. Abdullah, then Dr. Ammar, yes, Dr. Fahad then. Yes. Dr. Abdullah, did you stop injecting, for example, or you continue? What is your plan now in coronavirus situation now? What are you doing regarding
this is a very good question, actually. Since the COVID-19, there is a lot of difference regarding which case is elective, which case is urgent that you have to proceed on. The elective definition, most of the controversy is in injection. So we'll find a lot of guidelines has already been there in the market. French, UK, Dutch, German, American. So I believe, in my opinion, that all injection, you can delay it for 2 to 3 months till you get a space to inject those cases. Because in most of the time, the curfew is going to be like in a very, very peak. Then they will decrease the curfew, so you refresh a little bit and you see the urgent patient in which you can inject. Then there will be another peak that you cannot inject. If you want to divide it to 2 parts, I will divide it to AMD, that it's better to inject because of the irreversible damage that the patient may get it. And the other, which is soft, is the diabetic macular edema, especially those who are already controlled, getting injected already before. I can delay them for 1 or 2 months with feeling comfortably.
Okay, thank you, Doctor. Any other comments? Same comment or different, Dr. Ammar?
Similar. I mean, I agree about diabetics. We typically could not easily, but more relax injection schedule, so could delay them. I just want to say that what we're doing a little differently with the AMD patients is that we have them not wait at all. So they come directly from the entrance of the hospital to the injection room, get the injection and leave. So that will minimize any waiting time for them. And we make sure that they basically have no waiting time whatsoever, so that they don't mix with other patients.
Okay.
Do you see him post-op?
No, we do not see them post-op. We see them after 1 month.
Okay, Dr. Fahad, you have any other comment? Or
no, it's very similar to along the lines of my colleagues. So in Sheffield, all of our AMD patients, we injected them in a week. So we did lots of lists to inject these patients in 1 week. And then we're planning their next batch of injection in 8 weeks' time. The other group that we were worried about were the CRVO patients, where they can get big drops in vision. But our DMO patients, if they weren't needing treatment, I was automatically deferring them. If they had treatment recently, I would call them and I would determine on a case-by-case basis. The vast majority, I was comfortable to defer, because they were subjectively very comfortable with their vision.
Okay,
There's
Dr.
been the odd patient where I have treated them because they've been quite affected by the visual disturbance from their diabetic macular edema. But as a rule,
so, Dr.
it's
Fahad,
the
thank
AMD
you.
I'm prioritizing.
Okay, we want to be very fast in answering because still we are having only 5 minutes. I think we are having Dr. Patrick for questions, or if you want, Dr. Patrick, please. I received message that Dr. Patrick want to talk. Yeah, please, fast. I have one questions actually, or a comment about the giving, because from my experience with using Illuvian till that Dr. Patrick ready.
Good evening for everyone. I thank you and your colleagues for your nice presentation and the nice intervention. And I'd like to ask Mr. Safar, Dr. Safar, what about the persistent macular edema, for example, exudative macular edema, especially exudate at the center of the fovea? Thank you very much.
Okay, Dr. Ammar, this question for you, please.
So I'm not quite sure I understand exactly.
He
asked about
the persistent edema in the central with hard exudate in the center.
Yeah.
Okay.
Well, we all know, I think, from our experiences and from studies that exudates will take a long time to actually go away when edema responds, but the exudate may actually take longer. So I typically, those patients will continue to keep them on monthly injections and monitor them and make sure that the exudate is actually reducing. If there is any identifiable microaneurysms in the perifoveal area that could be potentially lasered in a focal, modified focal, then I would combine that with the anti-VEGF.
Okay. I think we are having, I don't know, can you hear me, John, and team, Marvision team? Do we have more time, or we will stop on 11? Can I have information about this one? Anyway, I would like just to thank all dear colleagues, Dr. Fahad and Dr. Ammar, Dr. Abdullah. It was great to meet all of you, even virtually, but I'm very happy to see you all. And thanks for all our attendees and our dear friends that they have their comment either and or their questions. We are going to have also in the future a meeting, but inshallah, we are also preparing to be with CME accreditations. So the people, they can also benefit in a CME. We are trying this one, but it will be soon, inshallah. Nobody answered me, but we will continue till they inform me. I have one, cases actually in Illuvian. When do you give a top-up? I mean, for me, I have several cases, and a few of them, they are getting respond very well in very fast. Some of them, yes, they are taking time to respond. But when do you think there is no response and you want to top up them? Is there a time, and what type of top up you want to give?
Shall I go first?
Yeah, please.
So, like I said, now I'm a bit more relaxed. So I would give so I've made a decision. This is refractory. I want to switch to Illuvian. I would wait 3 to 4 months. So long as I'm seeing a continued improvement in the anatomical profile or an improvement in vision, then I may not do any additional therapy. But if I see that there's a worsening compared to a previous OCT scan where there's been an improvement, if it's outside the FAS, then I would consider macular laser. But if it's center involving and it's a worsening and exacerbation, I would then consider an intravitreal anti-VEGF.
Yeah, I agree.
Okay, can I have a comment, Dr. Ammar? I think they give us a chance also to continue. No worry about that. Please, can Dr. Ammar, you have any opinion, or Dr. Abdullah?
I mean, it's the same thing. I would probably, again, I don't have very long experience, but I would wait probably 4 months or so, as long as we're not noticing any drop in vision. But that would probably be my time where I would intervene with an anti-VEGF.
I do the same, actually. Most of my cases, I top up after 1 month.
You top up after?
1 month.
after 1 month of Iluvien injection.
Yes, because patient has been waiting for 1 month before I see him and judging that he is not improving. So I give him another month after the Iluvien injection. If he doesn't improve, I give an top up anti-VEGF.
You are not waiting, for example, 3 months to get the improvement.
For Iluvien, no, because of the same reason I'm saying the loading dose.
So you're really wanting to speed up the rehabilitation of that patient.
Exactly, because I believe time matter in macular edema as any other disease.
Okay, suppose I'm thinking about if there is a patient, it responds very nicely to Iluvien, then start also again. You know, sometimes you will find cases that after they are improving nicely after Iluvien, then start also having increase in the edema and start losing a visual acuity. What time, I mean, you have to interfere?
Whenever I see him get worse, I will inject him.
Inject. Okay. Do you, Fahad or Dr. Abdullah or Ammar, inject and top up with steroid? Do you have any experience?
I have. I think that question was asked before. So there has been the odd patient where, I've given them Iluvien, they've been very dry and they've got a really bad, they had an exacerbation, say a year later. In those patients, they had absolutely no response to anti-VEGF. So most of the time it's an insufficient response, but they had no response. So I just gave them another steroid. They had a good drying with no increased problem with pressure.
Okay. Abdullah, I think you are loving that. Mean you are not interesting to this. Okay, actually, I have a case. That's why I asked this question, because one time I discussed this actually with Dr. Fahad. I have one case and it was improving very well with Iluvien. Then one of sudden start losing the visual acuity and also increasing in the macular edema. But I found the macular edema very high. It's not, dramatically, it's increased. In this case, I top up with steroid. I don't have, any study about this one, but whenever I thought it's a very huge increase of macular edema, I top up with steroid and it worked very nicely.
Yeah.
And then it continued. But I have another case, the macular edema, it was not that much. Then I top up only with anti-VEGF. I thought about they will respond maybe better. So maybe in the steroid tab, we need only to increase the dose or the steroid to be higher so they can respond very well. And both
I agree.
I agree about this one. This is my experience. It is a very small, some few cases, but still I do this one. This is my, and I was asking Fahad if there is anything that can support my thinking. We didn't find at that time, but we go for that, and it worked in this way. There is so many people, they are asking, about the Iluvien, if you can go directly and inject Iluvien as a first choice. Is there any cases that you do it as a first naive patient with Iluvien or not?
I think no anti-VEGF challenge?
For you, because you are the one most having a lot of experience with that.
So in the UK, we can't give Iluvien treatment naive. They normally would get macular laser or anti-VEGF prior to introducing Iluvien. So I've only ever used it as a second-line agent.
A second line, okay. Because also there is also a lot of questions came or debate, because here in UAE we get the approval that came from FDA approved. I think the same for Saudi Arabia. That's why we have to give a trial of Ozurdex. But I think it can be given as a second without using Ozurdex as an European approved, right?
Yes.
Okay. Is that also known, Dr. Ammar, or anyone who wants to comment about this one?
I think, go ahead, Abdullah.
Ammar, please.
I think in our market here, at least in the private sector, we have to follow the approval of the insurance, which follows the license. So our license here is is we have to get a challenge, but it doesn't really have to be Ozurdex. It has to be a steroid challenge. So you can potentially just give them drops, Pret Forte or something like that. Unfortunately, I mean, this is one point I might actually want to make right here, is that don't always just immediately presume that if they don't respond to Ozurdex even, that they won't get any response. Like Ahmed Al-Bar'i said before, and I've had also cases where they do sometimes develop late response. So it's not a 100% guarantee, but yes, it does weed out a little bit of the ones that do have a response. And then the question begs the question. So, okay, let's say someone does respond a little bit and their pressure go up to 23, 24. Does that mean they're excluded? It's total contraindication for not giving them steroids, or is it a relative contraindication? I don't know. These are all debates that we can stay until tomorrow morning talking about if we open these kind of forms.
By the way, is there any contraindication for Iluvien? Anyone who have?
Yeah, I think if
glaucoma,
uncontrolled glaucoma or infection, have to be very careful.
I mean, if someone is using steroid before Ozurdex, I mean, is after that there is a contraindication for Iluvien after giving Ozurdex? No.
No.
Let's say the question in another way.
Abdullah, I'll let Abdullah answer this one. Yeah.
Abdullah, okay, Abdullah, please. If there is a patient, suppose he is having macular edema, and you give anti-VEGF, then you give Ozurdex, and there is no pressure, and some patient there is a pressure. I mean, this is two groups. Okay, is there a contraindication to give Iluvien if there is if it is controlled or not controlled? So now it's 4 divided questions. Okay, Abdullah.
Yeah, actually, unless it is, if it's controlled, of course, I will give injections, and unless it is very high, uncontrolled, so I really will take care of his uncontrolled blood pressure rather than thinking of macular edema. Then whenever he arrived to a control level, I would inject him. As you see the video, patient has a glaucoma, I inject. Patient has a cataract, I inject. And I believe that those requirements is different between country and country. I mean, the guideline, the indication, different between country and country. Like UK, it should be pseudophakic. In Europe, they don't ask you to do a steroid trial on it, or rather than Bridford, rather than Ozurdex. While in USA, they ask you to try Ozurdex before. So there is a difference between country and country. And I believe there will be in the future a change in the guidelines in which that you will feel more comfortable to inject even a glaucomatous patient or even a cataract patient. No one at the level, or let's say the most of those patients came for diabetic macular edema 10 years after type 2 diabetic macular edema. They have cataract by default in most of the cases. And I don't think this should be a reason. In some center in Europe, the first line is corticosteroid.
Yeah.
And if the patient doesn't improve, they inject him or top up with a corticosteroid, actually.
Okay. So is there different comment about this one? Or can we go to another questions? We have one question also. What is the preferable? I mean, if you have a patient with a good visual acuity, and the one who is asked the question, he said, vision about 6/12 or 0.5 or better, and what is the criteria choosing here, Iluvien or Ozurdex or a grid laser? If there is any comment about this question from anyone.
Repeat the question again, Mohammed.
Patient with a good visual acuity and good OCT, and he's having still edema. What is the criteria to choose or to select between inject Iluvien or Ozurdex or to do a grid laser?
I would go for a grid laser in that patient. So if they've got mild edema with good vision, but it's just that if there's global thickening, I would consider a fluorescein, and I still use a lot of grid laser in my own care. I'm only really thinking about intravitreal therapies if there's central involving edema, obviously, and there's vision decline.
Okay, I mean, is there, I mean, different if you are selecting this patient, if it's a central or you are having somewhere, I mean, a site that you will do a laser. Suppose there is no site to do a laser, obviously, are you still going to give a laser or you're going to give anti-VEGF?
So if there's central involving edema and they have good vision, I encourage all the panel, all the attendees to look at Protocol V, which is one of the latest trials published by the DRCR.net, which is the American Diabetic Research Network. In that particular trial, if you observe the patient very closely and only injected with intravitreal therapy, which was Eylea in that trial, when they lost 5 letters at 2 visits or more than 10 letters at 1 visit, the proportion of patients who were still 6/6 was the same if you treated them at baseline. So they were 6/6 with thickened macula and you treated them, or you waited the vision to drop. Those patients where you waited did not come to any additional harm. The proportion in the 3 arms was still of getting 6/6 was still equal. So I now feel very comfortable to watch those patients closely and only intervene if there's a decline in vision. But the point is, you have to watch them closely. You can't leave them for 6 months or 1 year. They have to be seen regularly in order that you can intervene at the right time. And for a lot of patients, that will come as a relief because you see the problem, but they are not convinced that there's a problem. So it's about waiting till it's the right time and giving it at the right time.
Okay, any other comments from another dear colleagues here?
I just want to add regarding, we should differentiate between the macular laser, between grid and focal. Grid, okay. I stopped doing grid since many years now. Focal laser, I'm doing focal laser whenever it's not central, as Dr. Fat. And as he mentioned regarding the protocol and most of the study, they talk that whether you inject related to the anatomical OCT or to the visual acuity, what you're going to choose, which one? Better to have both, but sometimes it's become confronted between each other. I would believe the anatomical rather than the visual acuity because of simple reason. Most of the human being seeing better than 6/6. So if the patient came to you with a 6/6 visual acuity, but with a macular edema, it doesn't mean he doesn't have a deterioration in his vision. He may be seeing much better than 6/6, but he came to you with a small deterioration of his vision, then he sees 6/6 with this macular edema. Macular edema is not a normal thing. I would rather treat those patients who is 6/6, but he is believing on me if he has a macular edema proven by OCT.
Okay, Dr. Abdullah, I think there is a debate about to give injection in a case of 6/6 visual acuity, because I don't know, we have several cases, and I select for me and my dear colleagues, Dr. Abdullah, we are collecting several cases. They are having also a visual acuity, even drop little bit, 0.9 or 6/6 partially, and there is an edema, but we have to do a blood sugar control. We do this one for the patient. After 1 month, they came with no edema. So we are not, we don't need to go this is my opinion. And
it's a good point. It's a very good point. It is the osmolarity which caused the edema at the beginning, because when the patient has a lot of blood sugar in his blood, a lot of fluid shifted to the central circulation. And when he started the insulin or the anti-diabetic medications, you start to decrease the osmolarity by decreasing the glucose. Glucose causes osmolarity. This is why they urinate much. And when you decrease the osmolarity, the fluid shifted from the central to the peripheral, so he started having macular edema. I agree with you. Those who are newly diagnosed or those who are newly changing medications, we should be patient with them rather than rush for injections. But whenever I see macular edema, anatomical changes, I believe this is not normal. I'm talking about intraretinal changes, not subretinal fluid. As you know, subretinal is more safer than the intraretinal.
Any comment, Dr. Ammar, about this one?
No, actually, I agree with all the comments.
Okay. Is there anyone who raised his hand and he want to ask? I think Dr. Safwan, I don't know if he is still half or it is the same as before. I don't know. Dr. Safwan?
Hi, everybody. Just a small comment to Dr. Ammar Safar. Definitely a very nice discussion later on. For the microaneurysm, I have a few cases, but luckily it wasn't subretinal. One of them is my relative. He presented with the epiretinal hemorrhage, a dumb over the macula, and it was very nice from one side microaneurysm from the upper part that leak to the subhyaloid. So it was subhyaloid epiretinal. So here I had the chance to do a YAG laser hyaloidectomy in a way that the blood leak intragel and disappeared. And within 1 week, it was returned back to the normal. So just I need just to add this comment to the case that he presented. And definitely, I had two more cases that I have to do I had to do the vitrectomy for them, but luckily even they didn't have a subretinal. Thank you.
Thank you, Dr. Safwan. Thank you very much. You want to do any comment, Dr. Ammar, about that?
No, but I agree. You know, when the blood is only subhyaloid, then the option for YAG is definitely there.
Okay. I ask the friends here, team Marvision team, is there anyone who want to have a question, because most of the question answered. Is there anyone who want to ask a question? If there is, please, you can highlight and give the chance to ask. Otherwise, I think Bilal, we have Dr. Bilal Haj. Okay. Can we hear Dr. Bilal? Yes, Dr. Bilal. Dr. Bilal, yes. Open.
He's muted, actually. He's muted. Someone has to.
Yeah, I think they will open now. Please, Dr. Bilal, you can just remove the mute and open the mic and start ask. Dr. Bilal, if you can hear me, please. John, it's possible to open from your side?
Okay, I tried, but he needs to press
Okay.
it to allow.
Okay, so I think he is not able to ask a question. Is there any other questions? Any other want to ask questions? Okay, I think we are already more than 2 hours. It was a very interesting meeting. I would like to thank dear colleagues, Dr. Fahad, Dr. Ammar, Dr. Abdullah. Really, I was very happy to see you all. And also, I'm very happy that we hear a lot this meeting of dear colleague friends from different parts of our area. And it was very interesting. And we hope that we meet you also soon. And before we leave, we are going to have another meeting on 13th of this month. And we will have on 20 also and 2nd. And it will be, I think, the 22nd, it will be also with CME accreditation. So we wish to see you all again. Thank you for Alimera sponsoring this meeting. Thank you for Marvision team for helping us in this Zoom. And thanks for all. And good night and see you all.
Thank you so much.
Thank you.
Good night.
Thank you.
Yes.
Muhammad, Ammar, and Fahad. Thank you.
Thank you so much.
Thank you.
Take care.
Thank you all.
You can close the external. We can stay the other colleagues.